We're recording the session today because quite a few people from the task and finish group couldn't attend. And also Courtney, who's from the European Lung Foundation, and Imran, who's from the University of Aberdeen and the European Association for Urologists. It's a joint event, and they'll also use this webinar for their training of their patient representatives as well. So welcome everyone to today's webinar. I think many of you know me. Wrong slide. My name is Matt Boltz-Johnson, and I'll be chairing today's webinar. We asked the patient groups involved in the ERNs what they wanted to focus some training or capacity building on. And there was two main areas. One was on identifying or being clear about where is there added value of patients' involvement in the development of a guideline. So at what point should you take part, and where should you be involved in everything? At which bit is it more relevant for you to take part? So today's webinar will be structured where we explore each of the specific stages of developing a guideline and do a deep dive into where patient involvement is best focused. And the stages which we are structuring this on is the preparation and scoping stage. We're going to do a bit of more in-depth around the research stage, specifically because we want to look at patient involvement around a guideline with a systematic review, or where there isn't the evidence, where patient representatives can be involved in the consensus building. And then the third stage would be the writing of the guideline. We have Q&A sessions at the end, but because it's a small group, please, I'm sure you can raise your hand, and our presenters will be happy to answer those questions as we go forward. As I said, I'm delighted to be working with Imran and Courtney. Imran is part of the methodology committee in the European Association for Urologists. He's an editor on the Cochrane Urology group, and he's also a research fellow at the University of Aberdeen. So Imran comes with a huge amount of experience and knowledge about how to lead the development of a guideline from the technical perspective of a professional society like the European Association for Urologists. Could you just mute yourself, please? Thank you. Courtney comes with a huge, it's great to have Courtney back. I think, Courtney, last time you were part of this, I think you were about to go off and have a baby. I think the baby's now a toddler, so it's been a while, so it's great to have you back. Courtney is a patient involvement and engagement lead at the European Lung Foundation, and is actively supporting patients' contribution to the development of a guideline, supporting patient groups to engage into a guideline development of a European society like the European Respiratory Society. So the reason why I think this webinar will be quite interesting for everyone, Courtney comes from supporting patients to contribute into the guideline process, whereas Imran gives a perspective of how to involve patients in the guideline process, which a professional society leads. So the two views together, I think, will be quite interesting to see. Is Imran struggling to get patient involvement, but Courtney has the answers, or does Courtney struggle with getting patients to be involved in systematic reviews, and Imran can help? So I think this should be a good dialogue between the two. The overview of today was when we develop a guideline, there is 4 stages in a very simplistic way. There's the preparation stage, the research stage, the writing of the guideline stage, and the implementation. Today, we'll focus on the preparation, research, and writing, and the next webinar will be on implementation. We have a short video which we thought would be helpful to share of a patient representative involved in a guideline being developed by the European Respiratory Society. So I'm going to play that for you now, if that's okay. We were laughing earlier because we've got my Lady Gaga YouTube videos prepared as well. So let me know if you can hear Courtney. I can see you.
It needs a little bit louder.
When he was 5 months old, it was the first frost of the winter, and we picked him up out of his cot and he was wheezing, and you could feel the wheeze. You could pick him up on his arms and you could actually feel the wheeze. We took him to a doctor at the GP, and the GP said it was just a wheeze, there's nothing to worry about, he was just a wheezy baby. This occurred pretty much all that first winter. It's just incredibly frustrating because you know your child is ill, but everyone's just telling you it's just a virus. It's just a wheezy child. We were having to adapt our lives and Edward's life to accommodate a condition that we didn't know what it was. We knew it was chronic. We knew he hadn't got a diagnosis.
Connie, is that okay?
Parents are really important. A parent advisory group on these panels are really, really important because you've got, there's a huge range of medical and healthcare professionals, and they have a perspective. They don't live with the condition day to day. They haven't lived with it year to year. For us, if these were in place 10 years ago, it would have made a massive difference. We don't know how much more damage might have been done or has been done because he didn't get the diagnosis, because we weren't treating him with physio as we should have been, or giving him the right, medications, or giving him antibiotics as frequently as he needed them, because it was just, it's classed as just a virus or a wheezy baby or whatever diagnosis they gave at the time. So it's really important. I didn't realise, fully appreciate how much work goes in. Every one of those guidelines, every one of those points has been debated. There is research behind it. It is amazing. And the panel consisted of everyone from professors of respiratory medicine to physios to respiratory nurses to all sorts of clinicians. But they all had respect for each other, and they all had respect for each other's perspective. And also, different parts of the world treat things differently, or look at things in a different way. And it was fantastic. The work carried out by the chairs of that panel, Professor Anne Chang and Professor Amy Kantar, was phenomenal. They really kept everyone together. I'm really proud of the document. I'm proud of the input we've all had. But I know I made a difference. And it's only, it might be just one word, but we were debating treatment, and we were debating talking about using physio and how important physio is. And after the diagnosis, physio has been the greatest thing that we've had. My son plays a wind instrument, plays the trumpet. That helps enormously, running, whatever. And it's those little pieces of information which perhaps as a medical professional you might not fully appreciate, or you might say, you don't realise that from a parent's point of view, that's what you can use. You don't have to do straight physio. It can just be incorporated into daily life. So that's what I think is really important. And that's, from my point of view, that's what I'm really proud of. I think that the guidelines will help everyone involved in this condition, because they're a pathway, that they're set down. So a parent can take this to the consultant and say, look, I found this on the internet, this is what I need. Or the consultant has a basis to start this on, to start the parents on the journey. And it's that I've said it before, but it's that consolidation of information. It's all in one place. And this is just the foundation. You know, there's loads of work going on in the future, and this is the starting point for that. And that's what's really important. That this isn't just the end. This isn't just, you know, this is it. It's carrying on, and that's really, really important.
Christina, there's just a caption, so I'll just read it for the sake of clarity. It just says that now the child is 14 years old and infection free for over 2 years. Upon diagnosis, we have to advocate with the respiratory consultants for Ed, the patient, to have his asthma medication stopped for because the levels were at a normal level, because the guideline, following the guideline, was helpful.
Thank you so much.
And the other advantage now for this young man is that he now no longer requires prophylactic antibiotics. The bronchiectasis thank you, it's a terrible name, manages the daily physio, and the new challenges still present themselves, most recently mucus plugs.
I'm pleased that it makes such a difference. I'm pleased that these guidelines are here, and that, you know, that people will not have to go on the journey that we've had to go on, you know, that we had to go on in the past.
Thanks, Courtney, for rescuing me. A dyslexic having to say that is not easy. So I think the video, we'll send you the link to the video, and you'll have the slides from today. I think the key bit is that the real added value of having patient involvement in guidelines, while we all understand that, how can that be properly inputted into a guideline development? Because the clinicians come with a clinical view, but the patients and their families come with a holistic view, and by bringing them together, it can really make a difference to the qualities of lives and the outcomes for the people who the guideline is related to. So today, let's get rid of that. We're going to now walk through each part of the guideline process, and we'll have Courtney present, and then Imran will contribute from his perspective, from a professional society's perspective. And we've just highlighted here in the preparation stage, the key activity which is done, which is normally the prioritization of the guideline topic, engagement with stakeholders on which guideline to select the topic area, get confirmation from a wider external consultation on the topic area of the guideline, develop the guideline group based on the scope of the guideline, which clinicians should be involved, which professionals, and then to further elaborate the topic areas selected into a scope. So mapping out the scope, which includes clinical questions. So that's a very high level overview, and I'm going to pass you over to Courtney.
Thanks, Matt. It's nice to see you all. I think there's a few familiar faces here. So yeah, as Matt said, I'm going to talk you through this first stage around preparation. And my focus is really on how patients can add value to this stage of a guideline process. And I've sort of split the preparation into what the guideline should focus on, and then I'll move on, go back one. If you go back a dot, please. Thanks. So the first step really is in selecting what topic maybe a guideline is needed in. And as a patient representative, it's really critical that you are involved in this stage. because often you will know where the gaps are. So as we just heard in Zina's video, they really struggled to get a diagnosis for their son for a long time. So maybe through discussions with other patients, maybe through the ERN, you know that some countries might have access to certain diagnostic tests, but maybe that's not available in your country. So you might think, okay, maybe we need to know what's the best way to diagnose this condition. Maybe a diagnosis guideline is needed. And it's, really valuable to have patient input in this stage, because often you know where the gaps are and you can help to start prioritizing. So you could do that through the conversations with the ERN leads, maybe through your EPAGs, through patient advisory groups, or through maybe a priority setting survey with your patient community. Can I have the next dot? Thanks. So once you've sort of set the overall scope, you then need to start pinning down in a much more detailed way what your guideline is going to focus on. So that typically is done through setting PICO questions. So PICO stands for population, intervention, comparator, and outcome. And that's a much more detailed, you're really pinning down what's the population, what age are they, what characteristics do they have, what disease area, do they maybe have a specific gene or specific type of treatment. And again, patients can add a lot of value here. At the minute, I'm working on a guideline around palliative care, and the professionals had set their lovely PICO questions, and they said they wanted to focus on patients with severe lung disease to see if palliative care is beneficial. And the patients on the panel said, well, actually, we feel that palliative care is useful at an earlier stage. You don't have to have severe lung disease before maybe palliative care can be helpful. And that's also what the evidence shows. So the PICO question was changed based on that suggestion from the patient representatives. So again, in this stage, you're able to have input to say, these are the questions that we want answered. This is the information that we need to make informed choices about our healthcare. So having those conversations as part of the guideline panel or part of the working group can be really beneficial. The next one, please. And then also in this stage, you are starting to identify which outcomes are important from a patient perspective. So as part of the PICO questions, you will need to start setting out which outcomes you'll look at in your systematic review, which is the next page. So outcomes can be very diverse. Some would apply to lots of different disease areas. So it could be things like hospitalizations or quality of life, or it might be much more specific to your disease. One that I see a lot in respiratory is breathlessness and fatigue. So at this stage, patients can start to say, well, hold on a second, we want to know if a particular treatment improves fatigue, or if it makes fatigue worse. Does it make my quality of life better, or does it reduce my quality of life? Because if those outcomes aren't included in the systematic review, then the final guideline might not answer the questions and might not help you make an informed decision because that wasn't included in the first place. So really having patient input at this initial stage in preparation and scoping is really important. And then as part of the outcomes, you can also be involved in the voting or the ranking. So perhaps it's more important to you to know about fatigue over and above quality of life, or is it more important to know about hospitalizations? A guideline can't necessarily collect all of the information on all possible outcomes. So there has to be a bit of a prioritization, and you'll be able to say as a patient, these are the outcomes that are really critical for us. Next slide, please. So at this stage, we also need to think about who should be involved in developing a guideline. Next bit. So patients can and should, in my opinion, be on the guideline committee. And ELF, in the guidelines that we work on, we always try to have 2 patient representatives on the committee. We recruit them openly, maybe through patient advisory groups, through patient organisations that we're in contact with. And we also have processes in place to make sure that there are no conflicts of interest. So, for example, if someone had shares in a pharmaceutical company, and really, thinking about openness and diversity here, it should also include thinking a little bit about, do the patient representatives come from different healthcare systems? Because sometimes, particularly in rare diseases, access to specialists might be different in different countries. So by having different voices and different representatives, that can be really helpful. And maybe the patients on the committee can also be supported by a wider patient advisory group, or that they're able to kind of consult a bigger group of patients who might have experience of the topic. Next dot, please. And so if you're on that committee, or if you're involved in the guideline, you also need to think about, how do you get the wider perspectives? Are you part of a patient organisation, so you can have those conversations easily? Maybe you're part of Facebook groups, online forums. Maybe you could run a survey to try to get those wider perspectives. And really, so for example, I was working on a guideline recently around diagnosis, and they were looking at 12 or 13 different diagnostic tests. The patient on the panel hadn't been exposed to all of those different tests, so she couldn't really comment on how easy or difficult or accessible a certain test was. So by having other people to input, that can help to make sure that you're kind of really gathering that patient perspective. Next bit, please. And then it's important to make sure that people who are involved, the patients, feel well prepared, and they feel that they're able, they know when they can contribute, they know where they're, what the role is and what they're being expected to do. So at ELF, we provide training through the European Patient Ambassador Programme, and it's not specific to respiratory diseases. Anybody can do it. It's an online course. We also then would have calls between the chairs and the patient representatives, and we've got some guidance documents for professionals, for the chairs who are involved in, who are working with patients on guidelines. Suggestions around, think about the fact that people who are patient representatives might be living with an illness. Think about the length of meetings, make sure you've got regular breaks, thinking about, maybe you might talk about topics that are quite difficult as a patient to kind of be exposed to, and some of those conversations might be quite emotionally draining. So just some considerations that chairs should take into account. And then the next. And then I think it's important at this preparation stage already to set out for the patient representatives where you expect them to be involved and what the timelines might be. A guideline can take quite a long time to develop. The systematic review bit can take a really long time. So, this first stage, the preparation stage, tends to be quite busy. There might be lots of meetings, lots of emails, voting, doing different things. And then it can often go quite quiet for the patient representatives. And then maybe in the sort of, once you're developing the recommendations, it gets busier again. So sort of setting that out at the beginning can be really helpful as a patient rep, so that okay, I haven't heard from them in a little while. We're still in, they haven't set their people questions yet. What's going on? I'll get in touch with the chairs. Whereas once maybe, okay, they're doing the systematic review, that's all right. Maybe I've not heard from them, that's fine. So that was that side. And then I think, how am I doing for time? Okay, then just if you go on to the next one. So this was just an example of this. I personally wasn't involved in this. My colleague worked on the sarcoidosis treatment guidelines, which is a rare lung disease. And in that, they had 3 patient representatives on the committee, and they all were representatives of patient support groups. So they kind of had that wider group of patients that they could consult and draw on their experiences. And they came from 3 different countries, so they had experience of different health systems. The clinicians developed 8 PICO questions initially, but 2 of them were then changed to reflect topics which the patients felt were really important, and that included fatigue and pain. And alongside this, sort of when they were developing the PICO questions, ELF ran a multilingual survey, and we got over 1,800 responses, which I think is probably one of the biggest responses we've ever had. And that patients were asked to rate the importance of the different outcomes. So, you know, we had, although maybe 3 patients on the committee, we had that huge number of patients then who were saying, actually, these outcomes are really important to me. We published that paper, and I can share that with you afterwards. And from the survey, patients said that quality of life and functionality were the most important outcomes for them. And that then carried on through. So the systematic review found information on those outcomes, and the final guidelines were also reflected and were informed by those patient views. So yeah, that kind of shows you how it's worked in a real guideline. So I think not, unless Imran has anything to add, then we'll go to Lenya, I guess.
Yeah, no, I fully agree with you, Courtney. Thank you so much for such a nice summary of the preparation stage. Just one point I want to highlight is about patient representative and their role. Obviously, it's crucial and very important. And our experience is similar at the EAU. We do engage with patients. But one thing which I want to highlight is sometimes it's difficult to find patient representative, especially if you are dealing with some sensitive topics and patient, they don't want to reveal it to others. And because in urology, sometimes, you know, like it's difficult to have patient representative with that sexual and reproductive health problem, because people, they don't want to be identified as. So it varies from guideline to guideline. And because we have got 20+ guidelines, so in some panels, we have got a better patient representation, whereas in other, because of these issues or challenges which we come across, it may not be the same. What's your experience about like sarcoidosis or rare diseases? Because I can see even in rare diseases, sometimes it can be difficult to identify patient representatives.
Yeah, absolutely. That's something we struggle with sometimes as well. Trying to find patient representatives. I mean, bronchiectasis, which seen in is also a rare disease, and that I think surprised us because there was no European organisation, and we did sort of an open call and actually managed to find quite a few people, sometimes because there's not a lot of activity in that area. But yeah, it can definitely be a challenge. And as well, like you say, sometimes people aren't comfortable then for their name to be published alongside guidelines to their employers or, you know, friends and family that they have that condition. So that's something, yeah, we have to be conscious of as well.
So thank you, Courtney. Just to add on that point, I did some work on a guideline for a genetic tumour risk syndrome where people had a higher rate of malignant tumours and risk of getting them quite frequently. And there was quite a few of the patient representatives who didn't want to be recognised, but we supported them to contribute in a way that their details weren't shared or visible because of the sensitivities around that. So I think that's a good point. Just before we move on, was there any questions about, we focused in on the scoping, the preparation of a guideline and focusing, was it really clear where patients can contribute and where there's added value? Is there any questions on that or areas of clarity before we move on? Hi, Ilyara.
Yes, it's me.
Ciao.
Hello. Ciao. Hello, everyone. Thanks for organizing these meetings. Courtney, I found very interesting the idea of developing a survey to collect the wider perspective. How did you manage to organize it, and who did support it also economically? I mean, thank you for answering.
It's a good point. So European Lung Foundation is funded primarily by the European Respiratory Society, which is the professional body. So sometimes we get some funding from them to run surveys, or ELF pays for it. I think the thing I would sort of suggest to you, because I'm conscious, you're working in rare diseases, you might have less funding available, is it doesn't always have to be very formal. So if you think about, like, if you're on Facebook, for example, if you're maybe on a Facebook group, you can quite easily run polls to kind of just get a sense of what people think. So it doesn't necessarily have to always be very formal research that you might publish, but it might help you as a panel member to kind of get a sense, or say, oh, well, how does this work in your country? Do you have access to specialists, or do you have to travel very far? How would you feel about a treatment that you can take at home versus something that you have to go to the hospital for? So you can still kind of get that sense of what the wider patient community think. Because yes, surveys, they're expensive if you're doing them in lots of languages, and it needs a certain amount of sort of administrative support, I guess, in lung research. We're lucky because that's part of my role, that we get the funding and I'm able to do that. But yeah, I would encourage you, I guess, to think about maybe alternative ways that you can do that for cheaper. I hope that answers your question.
No, thank you. Also, because I'm the patient representative in the development of guidelines with the ERS and the EULAR. So I think I will get back to you for your help and suggestions, Courtney.
Great, thanks.
Thanks, Eliara. Is there any other questions, Christina?
Yes, I have a question, because within the ERNI, and I suppose with also other ERNs, we have a lot of different guidelines that have to be done. Have one of the ERNs some basic guidelines or agreement with the members of the ERN, the health providers, how the patients should be included at what stage?
So Christina, that's a perfect bridge, because what we did is Lenya's going to present the methodology which has been developed by the Commission for the ERNs on how to develop guidelines. And we've reviewed that methodology and we've pulled out the key points around where patients should be involved, where the Commission are recommending to the ERNs to involve patients in the process. So Lenya will present now sort of highlights of what the Commission guidelines or methodology says on where ERNs should involve patients. So I think that was a perfect bridge, because we thought it was good to underline the points which Courtney and Imran will say.
Thank you, Matt, and thank you, Courtney, for walking us through how you see patient engagement in the preparation phase, or how you do patient engagement from the ELF side. And indeed, the consortium who is responsible for implementing the EN guideline program, in their material, they picked up on a lot of the things that you mentioned earlier, Courtney. So patients, it's stated that patients should advise on the guideline scope and the clinical questions. This has different components. So firstly, they should be part of the guideline development group, which is a multidisciplinary group, which includes healthcare professionals, patients, methodologists, and policymakers. And the chair of that guideline development group is responsible for ensuring patient involvement throughout the whole process. And there should be a patient advisory group, ideally consisting of 8 to 10 patients living with the disease in question. And the chair of this advisory group can be a former member of the guideline development group to represent the views of the patient advisory group. Patients are then part of determining the guideline scope or scoping. So they should be consulted to define patient-related elements that the guideline needs to address. and should take into account the patient's perspective in terms of the scoping approach. So how is the patient perspective included? And they should be provided with support, training, topic-specific information. And patients are part of formulating the clinical questions. So the initial draft of the questions is developed by the chair and presented to the working group for their feedback. And as I said, this working group should include patients and carers' views. And in terms of the external review of the draft clinical questions, those are done by external experts, but also other relevant stakeholders are involved. And here again, these include patients and carers.
Thanks, Lenya. So, Christina, I want to underline, because I think this is really important. We have Anchor and Innis and the very nice gentleman from ERN Lung, Stefano, and they're part of the work of the guideline. The European Commission has set up a guideline group, a consortium to support the ERN's developed guidelines, and Anchor, Innis and Stefano are part of overseeing that contract and the project. And the reason why what Lenya just read out in terms of the methodology which is being proposed to the networks by the Commission is so in line with what Courtney has just outlined in terms of how ELF supports patient involvement. It's because of the advocacy work of Anchor, Innis and Stefano. So we actually drew on the experience of organisations like ELF to lobby the Commission to ensure that patient representatives were included in the guideline development group, and that there's thought around developing a small working group of patient representatives as well. That wasn't in there originally. So I really want to highlight the great advocacy of your colleagues, Anchor from Ernica, Stefano from Lung and Innis as well, because they really moved it forward. The question is whether the networks then use that methodology, and it's recommended, it's not mandated. So, and I think that we still need to work with the networks to see how best to use that methodology, but it is there and it is being recommended.
I just thought myself that I would like to have some kind of document of mutual understanding, how the patients have to be included into the guidelines within the ERNI, because there are very dispersed groups doing it. And independently of the methodology they choose.
So what we can do, Christina, because I think that's a good point, that this consortium which developed the methodology for the Commission, it's summarized in 12 handbooks.
Yes, that's what I saw.
If you ever feel like you can't sleep at night, you could just try and start at page 1 and see how far you get. But what I think we can do, and Lenya and I will look at it, what we take from today, we'll summarize in a very short 1-page or 2-page document. And then that's something which is references those manuals, and that empowers you to advocate in your network. Would that be helpful?
Yes, thank you.
Super. I'm going to carry on. So we're going to move to the next stage, research. In research, there's you've agreed the scope of the guideline, and then basically you get to research and you've got a fork in the road. You've got a choice of which direction to go in. If there is a big body of evidence, published material, I'm sure there is for pulmonary hypertension and cystic fibrosis, but less so for bronchosectomy. Sorry, Courtney. If there's a lot of evidence, then you can conduct something called a systematic review using the PQ questions. But if there isn't, and there's only a little bit of published evidence because it's a really rare disease, then actually you can do something called a modified approach and do some consensus building. So this next section on research we're going to break down into two small parts. One is when there's evidence and the other one when there isn't, and see about the approaches to involve patients in the two different sort of parallel lanes. Imran.
Thanks, Matt. So I will now summarize the process of conducting systematic review. So as Courtney, Manny, and Matt mentioned earlier, after the preparation stage, the guideline panel may identify a number of key questions, and we do systematic reviews. First of all, what are systematic reviews? In systematic reviews, we summarize evidence, or we identify studies and summarize evidence for a particular clinical topic. So suppose if I want to know whether the vaccinations which are currently used for the prevention of COVID, are they effective or not, I should do a systematic review, and I should summarize all the evidence that's available. If we are not identifying all the available evidence, then obviously there is an element of bias because we are cherry picking some studies. So first of all, we have to identify, or we have to draft or structure a clinical question. And Courtney mentioned earlier that we normally follow a PICO format, which stands for population, intervention, comparator, and outcome. This is the commonest format that's used for systematic review, but may not be applicable for all different types of questions. For example, if we are doing a diagnostic test accuracy review, then there is no intervention, but we have imaging techniques. Suppose if there is a new imaging technique, we can compare the new technique with an old one, which could be X-ray. So we will use a different format. So depending upon the type of research question, we will formulate a clear question using either a PICO format or a different format. And patient's engagement is extremely crucial and important at this stage, because they will identify and help us to know what are the key areas of research, starting from population, which population should be included, whether we should include all the adults or we should focus on a subset of the population. Sometimes we may also introduce subgroups that we have included all the adult population, but we want to look at the evidence separately for male versus females, or maybe adults versus children, or different types of subgroups. So their importance is extremely crucial. They can also help us to identify key outcomes, because if clinicians are making decisions, sometimes they ignore important outcomes. For example, if we are doing a systematic review on prostate cancer, clinician may say that overall survival or cancer-free survival is the most important outcome. But when we talk to patient, they may say, no, that's important, but quality of life is also equally important. So those areas are highlighted. So patient representatives, they play a key role when we formulate a clinical question. Once we have got a question, the next step is to write a protocol. Protocol is sort of a blueprint, how we will do a review. So we can refer back how or what type of methodology we will be adopting. It's a detailed process, and sometimes the protocols are also peer reviewed. Like in a Cochrane review, we write a protocol, these are peer reviewed and published. Once the protocol is written, the next step is literature search. And after the question writing and protocol writing, the engagement of the patient representative is very limited. And sometimes you may feel it's quiet area. So it's not like nothing is going on at this stage. People are working in the background with the literature search and other things. And normally it's important to tell the patients in advance that you may not hear emails or messages from us from the next 2 to 3 months, because this is a time-consuming process. But we would like to have focus input from you, and we will get back to you once we have reached data extraction stage or further ahead in the systematic review process. So the next step is the literature search. It's normally kept broad to identify all the studies. This is followed by abstract screening. So literature search may identify thousands of publications. And like for some big reviews, we have got like 10,000, 12,000 abstracts. And even for small reviews, there could be 2,000 or 3,000 abstracts. So it's a time consuming process. Someone has to screen or read those abstracts and identify the relevant studies. And normally this is done in duplicate to avoid selection bias. If suppose I am doing abstract screening on my own, I may introduce bias. So it's double check or it's done in duplication. After abstract screening, we normally identify full text or full publications. After full text screening, we identify relevant studies. I'm not going into minute detail of all these stages, just to give you an overall idea about the process, because we have got limited time. So full text screening, we will identify all the relevant studies. So studies are either included, excluded, or sometimes they end up in the unclear pile. Because like there could be studies in foreign language and the researchers, they are not familiar of that language. So we have to involve people who can understand that language and take their views. Or sometimes all the information that is needed at the time of full text screening is not there, and maybe we will have to contact the researchers. At the end of the full text screening, the studies which are included in a systematic review, we extract relevant data. Relevant data means what's the population like? What are the inclusion criteria of population? What are the exclusion criteria of the population? What sort of interventions are there? For example, if it's about antibiotics, which antibiotics are used? What was the dosage? Those sort of information. What was the comparator? Suppose if it's an antibiotic, whether it's compared against another antibiotic, or is it compared against like routine medical care? Those sort of things, or those sort of information is extracted. And then all the outcomes which are relevant are the information about them are extracted. For example, again, if it's an antibiotic, what's the cure of the infection? Those sort of information is extracted. Once the data is extracted, we may pool the evidence together, which means we may combine the evidence together using various statistical techniques, but we only combine evidence when the studies are similar enough. Because like if the studies are not similar enough, then there will be an element of bias. We call them heterogeneous studies, because like the studies, if they're not similar enough, we cannot combine them. We can only combine apples with apples. We cannot combine apples with oranges or apples with lemons. So the studies should be similar enough. If they are similar enough, we will combine them. We will do a meta-analysis and will present the evidence together. If they are not similar enough, that doesn't mean we are not summarizing them. What we normally do is called narrative synthesis, in which results of the individual studies, they are compared versus each other. This is followed by assessing the quality, which is also known as certainty of evidence, and we normally adopt the grade approach. So once the evidence is there, we assess how much confident are we in the result. Because like if there are issues or methodological flaws with the studies, we may not be convinced that we can rely on the evidence. And this is where the grade factors in. And once the grading of evidence is done, the final stage is to write the report of the systematic review separate from the report of the guideline, because normally we also publish systematic reviews separately as a publication. I will give an example to explain what I have just said about the process. But if you have any question about the process itself, I am happy to take questions right now, or maybe after giving the example. Okay, so I will move on with the example. The example that I have selected is about tension headache, because almost everyone has got headache once in a while. Could be work of the stress, it could be other factors which can cause headache. Now, suppose if we want to do a systematic review about medications which can be used for the management of tension headache or common headache, first of all, we have to identify the population. maybe the population is all adults who are above the age of 18. What could be the intervention? Intervention may be paracetamol. Comparator could be placebo or could be other drugs. And the outcome is pain-free in this particular review. I have kept it simple. Normally, there are multiple comparisons. There are more than one interventions. And again, there are more than one relevant outcomes. Usually 7 to 8 are the minimum outcome that we include in a systematic review. Sometimes they can be more depending upon how detailed are the topic. Once we have identified the PICO or structured the question, the next step is protocol development. This is followed by literature search, which may identify, because paracetamol is such a common drug, will identify certainly thousands of relevant studies. We will do screening of those relevant studies that were identified, and we will identify studies which meets the inclusion criteria. So suppose if there are studies about children, that will not meet our inclusion criteria because we are only interested in adults who are above the age of 18. So those will be excluded. Sometimes you will come across like mixed population, that they have included both adults and children in a particular studies. So you can include that study as long as they have provided separate result for your target population. After you have identified all the relevant studies, you will extract the data and you will combine them together, what we call meta-analysis. And the image that's illustrated below is called a forest plot. It's a technique to combine the result of individual studies statistically. As you can see that there are 5 studies, each line represents a particular study, each horizontal line. And you can see there are 5 studies. Now, the results are combined together, and you can see on the left-hand side of this forest plot, it says it favors placebo. On the right-hand side, it says it favors paracetamol. So it indicates that paracetamol is effective in reducing pain. So does it mean we are going to offer paracetamol to everyone who is coming with tension headache? Or do we have to look into various factors? Now, this is where the grade process helps us. We have to look into the quality of those studies or risk of bias assessment of those studies. If there are methodological flaws in those studies, then obviously we will carry less weight to those studies. Then there are other 4 factors as well, which we consider. I will not go into detail because of the limited time, but there are other 4 factors which we consider when we downgrade the evidence. There are 3 factors which may upgrade the evidence. At the end of the process, with grade approach, we classify or rate the evidence as high, moderate, low, or very low. If it's a high quality or certainty evidence, it means we are confident enough. No more research is required. The question has been answered. If it's a very low evidence, then more research is needed. If it's obviously moderate and low, then obviously it's somewhere in between. So there are 4 levels of quality of evidence. Next slide, Matt. Now, once we know about the certainty of evidence and we have rated it, in this example, we are assuming the evidence is of high quality. We don't need further research to answer this question. We are confident enough that paracetamol, as far as studies indicate, is good enough to control pain. Are there other factors we should consider? Yes, there are other factors. Next. The other factors are the balance of benefits and harm. Irrespective whichever medication I'm talking about, there are some side effects. Now, side effects could be rare as well. Like, like some side effects are very rare. They can happen in 1 in 10,000, 1 in a million. So we have to factor that in as well. So paracetamol, what are the benefits? It can be used to control pain or analgesia. It can also be used in patients who are having temperature or fever. For example, in patients who are having infection. So that's the benefit of paracetamol. What could be the side effect? Now you can see that it's a long list, but the clinicians or the guideline developer, when they look at these side effects, they also factor how common or uncommon these side effects are. As I said earlier, all the treatment, they come with some side effect. If the side effects are very rare, then obviously we don't have to put that much weight on them. I will not read all these side effects, but you can see there are some side effects associated with paracetamol. So there are benefits as well as harm, and it's the balance. If there are more benefit than harm, then the guideline developer will recommend a particular intervention. If there are more harms than benefit, then obviously the guideline panel will not recommend that particular intervention. Next, please. Now, after looking at the evidence and after looking at the ratio or the balance of benefit and harm, we have to look at the third thing, which is the cost of the intervention. If it's too expensive, then obviously we cannot offer that intervention. But if it's cost effective, then yes, it can be offered. So if we are confident about the evidence, if there are more benefit, and if it's cost effective, yes, it can be offered. Now, this is from 2019, and it has summarized the price in pounds of various painkillers or analgesics. And you can see paracetamol is the least expensive. So 8 tablets of paracetamol typically cost less than £1, is 89 pence. Whereas when we compare it with other painkillers, they are more expensive. So you can see at the top, it's like £9. So when I compare paracetamol versus other drug, is definitely more cost effective. And we are comparing the price of 8 tablets over here. Next, please. Now the next is patient values and preferences. And we have to factor that in as well when we make a recommendation. We can't have like one size fit all approach over here, and people may have different values and preferences as well. So even if the guideline is recommending something, sometimes we have to explore more about individual patients. I don't think we can do a poll, but like based upon the information that we have provided over here, and we are a small group, so maybe you can either put it in the chat box if you think you would like to have paracetamol, or we should recommend paracetamol if the patient is having headache, or you think it shouldn't be, or maybe you can be unclear as well. Unclear means you still need more information. So what will you do? Studies indicate paracetamol works to control pain. There are more benefit than harm and is cost effective. So should it be given, or what do you think? So 1 yes, 2 yes. Yeah, watch out for intolerance, definitely. Yeah, yes. Any other views? Okay. Yeah, depends on the level of the headache. Yeah, definitely how severe or manageable it is. Sometimes it's manageable with other things as well, like relaxation exercise or relaxation technique. So yes, so most people in this group, they think it can be offered. So based upon that, if we agree with what this group is saying, I think this recommendation probably is a fair representation, like offer simple analgesia such as paracetamol, taking into account comorbidities, which means other medical condition, and risk of adverse effect for patients with tension headache. Like comorbidity, as one of the side effects of paracetamol is it can damage liver. So suppose if someone is having liver problem, we should avoid this medication. So we have to consider that. So absolutely. And I think that was one of the comment as well. Next, please. Now, this summarizes the key messages or key points of patient engagement during the GRADE process. patient may weigh the benefit and harm, burden, and cost of treatment differently. Because, like we are talking about different healthcare system as well. So if patient is in the UK, where the healthcare system is free at the time of delivery, the value and preferences will be different. Whereas if we are talking about a patient who is in the US, so either the insurance company is paying or patient is paying out of pocket. So their values and preferences will be different, and cost of treatment. And sometimes there is indirect cost as well. Even in the UK, where the healthcare system is free at the time of delivery, there is indirect cost. Suppose if patient cannot work, or it has an impact on the other family members, so those factors may be considered. Patient might also raise question about the practicality of a particular treatment approach. So again, for example, if I'm in Aberdeen and if I'm asked to go to Glasgow, which is 130 miles from here, for a treatment, it may not be practical for me. Maybe I don't drive, maybe I don't have a transport. So those factors should be considered. And patient may highlight those factors based upon their experience or their other fellow patients, and help to ensure that patient will support outcomes of the guideline. So these are the key areas. And this was about systematic review and how the evidence is summarized. But there are situations when evidence is not available and we use consensus process. I will stop for a moment to take any question about systematic review or grade process before I move on to the next two slides. I've only got 2 slides about consensus.
Thanks, Imran. I must admit, I feel very reassured that that when it comes to doing a systematic review, it goes quiet, because it sounds like a headache, which you would need paracetamol for to process that level of information. But it was really helpful to understand that there's a point after grading, before recommendations are formed, where patient contributions around their preferences of weighing up the benefits and harms and the values and preferences can be put in. And I think that's an important bit, which I think is to underline to the group. Is there any questions to Imran about the systematic review process and where patients should be involved? No? Are you all following? Okay, yeah, there's a few.
I'm here.
Hi, Amy. Happy birthday, Amy.
Oh, thank you. I spend my day with you guys as a best present. So I was just looking at the research and the points you have there. Could you just say on each point which one is the patient involvement needed, or when it's not? Like the first one, you said that there's a patient involvement. The next one, a little bit more clearer. Would that be possible?
These, Amy.
No, from the beginning, the first one that you on the.
I see.
First slide, research.
Yeah.
This.
Yeah. So,
yes, that one.
So when we are formulating the research question, patient engagement is extremely, extremely important. The first step. Second step as well, some panels, they do involve patient while they are writing protocol, because, like when we are writing these outcomes, patient may contribute. So first 2 stages, and especially first stage when we are identifying the clinical question, extremely, extremely important. Yeah. Then the next 5 stages is quiet for them. So it's very quiet, like when we are doing abstract screening, full text screening, data extraction, data entry. But when it comes back to the grade assessment, this is where we look at the benefit and harms, patient values and preferences. It's very, very, very important. And if I have to involve patient in only one stage, this is the stage I should involve, because they are the one who can tell us the key factors about their values and preferences. and they can highlight issues which we or the researchers or the clinicians may never have thought of. Courtney, what do you think? I think you're on mute.
Sorry. Yeah, I would totally agree with that, Imran. I think if you've had, hopefully you've had patients involved in the preparation stage, which we talked about earlier, but the grade bit is really the crucial bit. So as you've seen, this is hugely a lot of work for the methodology team. In my role at ELF, and I'm aware, you will have different resources available to you. One thing that we sometimes do is we would almost copy this arrow and we would do that separately. But instead of looking for the scientific literature, we would look for literature on patients' experiences as a topic. So we call that, at ELF, we call that a patient-centered literature review. So that's where we look for qualitative reports, so things like interviews and focus groups, maybe surveys that have sort of explored patients' opinions of the topic, what's their experience, what's their perspectives, and that can help us. We tend to find very little. We might find, Imran talked about 10,000 papers. Sometimes we find 100 to screen, and of those, maybe 1 or 2 are relevant. So it's a lot smaller because not as many people do qualitative research. But sometimes if you have the capacity to do that, it can help to make sure that once you get to that grade stage, that as a patient representative, you're confident in knowing what patients think. So that when we're sort of talking, well, how would you weigh up the benefits and the risks? Maybe there's been some research on that. That's with good quality, and then you can kind of help to inform those discussions. If you're not able to do that, then there's other ways that you can do it. So you can talk to your patient advisory group, you can do an online poll, through Facebook, you can maybe do a survey. So there's other ways that you can help to collect your own evidence to help inform those discussions at the grade stage. But in terms of the kind of formal review of this arrow, this sort of diagram, patients don't tend to be very involved in this stage. I hope that helps.
Yeah, thank you.
I think I'll skip this slide. It just summarized the entire process, what I've explained. So yeah, I'll just skip this slide.
And why you need paracetamol.
Yeah, and why we need paracetamol. Yeah. Okay. So sometimes the evidence is not there, or there is conflicting evidence. We can use consensus process. And like there are different techniques, like sometimes we use nominal group technique, sometimes we use Delphi survey. There are other techniques as well. I will not go into detail. I will only explain what consensus is. Consensus means reaching an agreement. And it's not like all participants will reach an agreement. Sometimes we have like a pre-specified threshold. Like if 70% or 75% of the participant in a group, they are agreeing, we will take it forward. So as long as there is an overwhelming majority about a particular recommendation, we will take it forward. If there is no overwhelming majority, we can have multiple rounds. This is more about like Delphi survey. In Delphi survey or in Delphi consensus project, we can have multiple consensus statements. For example, we may do systematic review to identify a statement. We have got, for example, 100 statements. We will have a pre-specified threshold that if the participants who are included in those surveys, if 70% or 75% will reach agreement, it can go to the second round. In the second round, maybe out of those 100 statements, we have only selected 30 statements. And again, we will do the same process. And the rounds are repeated twice, thrice. And at the end of the process, we reach consensus. Now, what's the role of patient in these consensus building exercise? Their views are extremely, extremely important. There are two ways, or mainly two ways of doing it. Either they are the member of the same stakeholder group, or we do a separate exercise with patient. Now, if they are the member of the same stakeholder group, we have to make sure that they have a representative number. Suppose if there are 50 members and 40 are clinicians, 5 are researchers, and only 5 are patients, then their views will be diluted. So that may not be the best way of doing it as a group exercise. So maybe we will treat or create 2 separate groups, one of healthcare professional, second of patient, and then we will compare the results of the 2 groups, and then again we can combine them together using various statistical techniques and present the result overall. And that's usually my preference when I'm involved in a consensus building exercise. I take 2 groups separately, but then combine them together to make sure that the views of the patients, they are not diluted. So consensus process or project, they are done for making recommendation when there is low quality evidence or conflicting evidence. Surveys are done for clinical decision making. Consensus projects are also done for core outcome set development. Core outcomes are the key outcome for a particular interventions or other types of studies. Or it can be used to identify research uncertainty. For example, James Lind Alliance, they do priority setting exercise. And in Aberdeen, we did one exercise with them to identify priority settings or key questions in patient with incontinence. So role of the patient is crucial. I will give an example of one of such project to give you an idea how this project is managed in my next slide. Now, this was a prioritization exercise to identify key research questions in patients with prostate cancer. This prioritization exercise was done as part of Pioneer project, in which we have developed, or we are developing, a data platform in which we will have access to patients, millions of patients. So electronic health records of millions of patients will be there, and we'll be able to answer some of these questions. So in stage 1, we identified the evidence gap, or what are the key questions. We followed the PICO format or alternate format, which I mentioned earlier. And at the end of the process, we identified 44 relevant questions. Now, these questions, they were fed into a survey, and we had 2 separate groups. One was patient, the second was clinicians. Both these groups, they were asked to rank these questions on a scale of 1 to 9. 1 to 3 means they are not important for clinical decision making. 4, 5, 6 were important for clinical decision making, and 7, 8, or 9 means they are crucial for clinical decision making. The reason for separating these 2 groups was additional as well, because in the clinical or healthcare professional, we kept the language more technical, whereas in the patient group, the language or the surveys were translated in a plain language. So in round 1, 73 healthcare professionals took part in the survey, and 53 patients participated in round 1 of the survey. At the end of the round 1, all these 44 questions, they were ranked on a scale of 1 to 9. There was also an option of proposing additional questions. So patients and healthcare professionals, they suggested many questions. Some questions were already covered in our 44 questions. Some questions were such that they were not answerable by using big data, so they were again filtered. And at the end of round 1, we identified 12 relevant questions. So in round 2, we had 56 questions. So 44 original questions plus 12 new questions. And in round 2, 59 healthcare professionals took part in the survey. The round 2 questionnaires were also translated in other languages such as French, German, Italian, and Spanish, because we wanted to have a wider patient's perspective. The healthcare professional survey was only in English because we thought that most of the healthcare professionals, they do understand English and they will be able to take part in the survey. Whereas in patient group, we thought if we will only have surveys in English, then we will exclude the views of a big majority. And because it's a European Union funded project, so we selected languages which are commonly spoken in Europe. So that's why you can see there is some language bias, but it's because of the funding nature of the project. So 169 patients participated in round 2 of the survey, much lower number than what Courtney mentioned for her survey, which was more than 1,000. And you can see out of those 169 patients, we had 53 English speaking, 19 French, 31 German, 53 Italian, and 13 Spanish speaking patients. So again, the numbers are variable. They are not similar from each country. And again, like it was difficult for us to access patient and patient group from some of these countries, especially like Spain or Spanish speaking patient. It was difficult to get hold. And at the end of the process, we had 2 separate lists of key questions, and we compared the results. The results were very similar. So the top questions from which were identified by the patient, they were more or less same as were identified by the healthcare professional. And then we combined them together and gave a complete list which represent the views of both patients as well as healthcare professionals. And now we are trying to first answer the top 10 questions, and then we will go down the list. So this is an example of prioritization process to identify key questions or key evidence gap. I think this is my last slide. Yeah.
Thanks, Imran. So I think we're a little over time at the moment, but I think one thing just to highlight before we get feedback from Lenya about where the European Commission methodology guide for ERNs to develop guidelines where patients have been recommended to be involved. It was just to underline, I think, the point that grade has its limitations for rare diseases. So grade, you can highlight, score something with a high confidence, brackets, no more research is needed. I think it will be very difficult for any of the rare diseases to score high on grade, because there is always more research which is needed because of the small numbers of patients. We never have the level of research produced and published to enable the grade process to come out with evidence which is scored as high confidence or high value, high quality. So I think Imran's second point around the consensus building and working with the professionals and the patients to supplement what published evidence is absolutely critical for any guidelines for rare diseases, because that we need to draw guidelines and recommendations based on not just what is published, but what the experience of those professionals are in the ERNs, to ensure that we have something which we have the guideline drawing on the best available information and knowledge. I just want to highlight that. I think it's very Otherwise, it's very disheartening. We do a guideline for a rare eye condition, Christina, and we'll have the evidence marked as low, 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 low. And the recommendations Germany or France would not adopt because of the low quality evidence. We're always have that sort of hindrance of never having enough research available that grade approach by itself is enough. So the consensus building aspect of this is really important. Len, if you could just very high level say the feedback on these 2 points.
So yes, so thank you, Imran and Courtney, for summarizing the systematic review process so well and where patient involvement is critical. The handbooks say that even though it's a quieter phase, the systematic review, the research phase, that patients are part of evidence review and are there to ensure that recommendations address the patient's issues and concerns. And I'm not going to go into the details, but basically by being part of the guideline development group, they are part of reviewing the titles, the abstracts, the full texts. They are part of the final screening against inclusion and exclusion criteria. And the grade process and methodology and all of the other points listed here. So risk of bias, identifying indirect evidence, and rating overall quality of evidence. They're also part of the consensus building. They are part of the consensus panel, which is again multidisciplinary. And they are mentioned here 3 different ways of formal consensus building. So Delphi, patients are part here because they're part of the consensus panel. Then there's the nominal group technique and the consensus development conference. So depending on how many stakeholders or participants take part in the consensus building, different techniques are suggested. Next, yeah? No,
that's fine.
In terms of appraisal of clinical practice guidelines and consensus statements, again, there's an appraisal working group of which patients are part, and patients and carers are also involved, as Imran mentioned earlier, in the AGREE quality rating. They're part of the consensus statement appraisal. There is a development group for consensus statements, which they are part of, and they're also externally reviewing consensus statements for the sake of transparency. In terms of adapting and adopting clinical practice guidelines, again, there is a multidisciplinary adoption and adaptation working group, which they are part of. Especially when looking at acceptability and applicability, the patient's perspective is one important criteria amongst others, such as worth, population, intervention, resources available, barriers. The working group might consider additional literature researches and published literature on patient values is part of that. Again, probably there's not a lot of published literature, but then the patients that are part of the working group may advise the working group on other ways to get the patient perspective. And adapted guidelines are externally reviewed by experts in the field and other stakeholders. And again, patient representatives count amongst these other stakeholders to ensure quality, validity, and applicability of the guideline.
Thanks, Lenya. Yes. Just to recap, in terms of the systematic review, patients aren't really involved in that process, except if you're the 1 or 2 patient representatives in the guideline development group. And if you're involved in that guideline development group, that oversees the whole process. So you're automatically involved in the screening and of the publications, etc. But it's great to see that the commission recommendation is patients should be involved very much in the consensus building in any approach. So I think that's really helpful. Thanks, Lenya. Courtney, I'm going to say if you can cover writing in 5 minutes, then we sort of end the webinar. And then if people want to stay for questions, I'm sure we can stay a bit longer. But if you have to go, is that okay, Courtney?
I will try my very best.
Thank you.
So I think we have already covered quite a lot of this anyway. So at this stage, we're going from the systematic review to developing recommendations. And that's often done in a meeting called the evidence to decision meeting. So it's taking all of the grid information, all of that data that's been extracted and Imran talked about, and then you're starting as a group to discuss and say, do we recommend this treatment? What's the recommendation going to be? As part of that, your views are really crucial, as we said, weighing up the risks and benefits. One individual might be happy to go to hospital, once a week for a treatment, but maybe somebody else that would be really inconvenient for them based on the travel or the cost or their caring responsibilities. So you're starting to kind of weigh up and add in your perspectives there. Next. You can also, as I sort of explained with the patient-centered literature review, you can also start to fill in some of the evidence gaps, because often, GRADE has that system. It's asking you, what are your values and preferences, but maybe there's been no published information. So the panel will then look to you as patient representatives to fill in the gaps in the evidence, to bring your perspective. Maybe for some of you, a certain diagnostic test might cause a lot of anxiety, it might be uncomfortable and you're not really willing to go through that, but for other people it's maybe worth the hassle and worth the discomfort in order to get that diagnosis. Next bit. So the technical team will write the publication. They'll, gather all that information. They'll write the methods, how they did the systematic review, what the recommendations are, and then as patients, you should be asked to review that publication to make sure that those comments and the bits that you were contributing have all been included within the final manuscript, and that your suggestions haven't just been forgotten about. Patients should, and in our guidelines, we make sure that patient representatives are listed as co-authors if they've been on the guideline development group, and if they've been part of the wider patient advisory group, they're put in the acknowledgements to kind of recognise their contribution. And then next bit, sorry, nodding. The guideline will also then be submitted to a journal, publication, and it will be peer reviewed. Patients don't really tend to be involved in that stage. Depending on the journal, some journals have patient reviewers, but not all of them do. So I think I've got a couple of examples of this in practice. So yeah, I think we saw really earlier in the video, Zena talked about how as a parent, she contributed during those meetings to suggest that physiotherapy can be incorporated into daily life. It doesn't have to just be in a physiotherapy session. So if you go on to the next bit. So this is, I've just given you an example of how this is presented. So the main guidelines for professionals.
Could you mute, please? Thank you.
So the main guidelines for professionals suggest that physiotherapy or airway clearance techniques should be individualized and that they might need to be adapted as the child matures. And then ELF takes the professional guidelines and we make them into a lay guideline. And you can see here how we've done that. We've said, it can be incorporated into their daily life and it might, need to be adapted as the child gets older. So again, this is an example of where that contribution from the parents really added a lot to the final recommendations. Next slide. And this was just an example to show how patient-centered literature review got included. This wasn't a guideline, it was a statement which kind of follows the consensus process, which Imran just talked about. So we really struggled to find a patient representative to join the panel. So we agreed with the chairs that we would do a patient literature review instead. to understand their experiences of chest ultrasound. I found no published evidence on the specific topic that I was looking for. I found 4 articles that looked at the use of ultrasound in emergency department settings. I was interested only in chest ultrasound in different settings. But there was still some information there about sort of patients' views and preferences. So I was able to identify some themes, things around discomfort, anxiety, but also things like it can be reassuring for patients. It's a non-invasive type of imaging, and it reduces exposure to radiation from CT scanning. So those considerations went into the final statement, and it also helped to identify recommendations for future research, that actually there is no research telling us what patients' preferences are around this imaging technique, and we need to know more about what information needs they have. So that was just an example of how a patient literature review can really add to a professional guideline. So that's it from me.
So Lenya, I think we've run out of time now. So thank you very much, Courtney and Imran, for walking us through the first few steps of developing a guideline around scoping, preparation and scoping, the research and the writing. I know we booked this for an hour and a half and we've come to the end of that point. So I think we stopped the presentation there, but I think we can, if you're able to stay and you wanted to ask some questions, I think we can do a Q&A session now, if that's okay. Is that okay with everyone? Should we stop recording, Lenya? So
I have to leave you guys, but